Good afternoon. Let me just start by saying thank you to both of you for joining us today on this discussion. Everybody who's joined us in the audience today, it has been a day of distractions, I think, as we all know. And frankly, the distractions that we're all kind of working through this morning have real implications on the clinician-patient relationship in a lot of ways. And while we will dive into things the way that we were originally planning, I'm sure whether it's Q&A or towards the end of the session, we'll come back and talk a little bit about what this morning's decision means for the patient-physician relationship. Before we dive in, I just want to spend a second talking about kind of where did this come from? Where did this session originate? I've been in healthcare most of my career, virtually all of my career. And the decision to get into healthcare, I am not a doctor. I did not train clinically in any way. But my decision to get into the healthcare space was very much tied to early interactions in my adulthood to the clinical relationship between a physician or a caregiver and the patient. And the first one, when I was in college, I went to the Dominican Republic on a service trip. My role was working on a construction team, but we had a healthcare clinic. And one day I got pulled into the healthcare clinic doing administrative work on the side. And what struck me in that experience was watching this line of patients kind of come to this pro bono clinic and watching them walk out on the other end with an entirely different expression on their face, an entirely different demeanor. They walked in uncertain, nervous, scared, questioning. They walked out feeling very good. You could see kind of the happiness in many ways on their face. And the irony is the vast majority of their needs we couldn't do anything about. The vast majority of what they were looking for clinically, we couldn't help. But what they wanted is they wanted to be heard. Like that was effectively what happened in that clinic that was magical beyond what any clinical diagnosis can provide. You fast forward a couple of years, I was in the Peace Corps doing public health work in the Congo. And we started this public health project. We were the first ones doing this project. What we quickly realized about 6 months in is the project was kind of ill-conceived. We were trying to deliver public health education that nobody else in the communities was all that interested in. And for about 3 or 4 months after that, I was incredibly frustrated because I had a project nobody wanted. And so after a few months of trying to figure out what to do, we started going out in the community with the clinician that I worked with, and we began asking people, what do you need? And we basically rewrote the project based not on what a bunch of administrators in a capital city told us needed to be done, but by what the community was actually telling us they needed. And the second year of my 2 years there was entirely different from the first because we listened and because we took the time to actually understand what the needs of that community and in many cases individual patients needed from us. That was the magic of healthcare. And that is what I think many clinicians got into healthcare for. At least when, so I'm the CEO of Envision Healthcare. We have 15 to 20,000 clinicians that we work with every day. And when we are out talking to them, they are not happy about what their jobs have become over the last 20 years. Most of them would tell you that. And at the heart of it is this. We have kind of lost the ability to listen and interact with the patients in the way that our patients need, and thus in a way that our physicians find fulfillment. And that really is the question we're trying to wrestle with today. Is what I just said true? Is that accurate? And if it is, what do we do about it? What should this relationship look like 5 years from now, 10 years from now, and then how do we get there? So that's what we're going to dive into today. Let me first hand off. I'm going to ask each of you to introduce yourselves and the organizations that you work with.
Me?
Yes, Melanie.
Hi, my name is Melanie Bella. I am head of partnerships and policy for City Block Health. CityBlock is a provider organization that provides integrated services, physical, behavioral health, social services, to Medicaid, dual eligible, and other low-income populations, typically in communities that have been marginalized and underserved, where there have been real access issues and real equity issues. And so those are the folks we want. Those are our people. And so we cherry pick for high cost, complex, a lot of challenges in life, and do that in partnership with payers. And through value-based arrangements or capitated arrangements, try to make that experience better. And so I also dabble in health policy. I have the privilege of serving on MACPAC, which is the Medicaid and CHIP Payment Access Commission, and prior to CityBlock, spent time in state government and federal government. So CityBlock is also an opportunity for me to see how policy translates in the real world, and if the intent of the policy, which is typically to provide a better experience and to provide safety and to provide access to people, if that actually happens when the rubber meets the road. And so excited to be here today to talk to you a little bit more about that.
It stopped raining just as you finished your uplifting work.
Yes.
So I'm DePlao. I'm a pulmonary critical care specialist, also boarded in infectious disease, and I currently run a health center, which is primary care based. So I've inverted the triangle from being a specialist to going back to my roots in primary care. I work at the Mount Sinai Health System, and as you know, at Mount Sinai, we were there during COVID, and certainly upending the physician-patient relationship. COVID certainly helped that a bit. That's who I am.
Thank you. So let me just start real quick. I'm going to frame. There's a recent survey that got done. 7 out of 10 clinicians basically say, hey, look, I am less happy than I was 10 years ago in my job. And I don't think, I see heads nodding. I don't think people are surprised by that. But there's real data to support it. And the other thing that they say is, I spend half my time in front of a computer screen logging things into an EMR. And again, I don't think that's a surprise. You're in healthcare, you, for better or worse, kind of know that fact. What we're seeing more recently is more and more clinicians also saying, and I don't plan to stay in this as long as I originally thought. And we actually, we're in a unique space. We were really very much on the front lines of COVID. But we have seen a rash of retirements that's unprecedented. It's unlike anything that we have seen in my lifetime and our lifetime. And I don't think that's over. And while it has been disproportionately impacting some subspecialties, I think it is likely that it is going to continue into other specialties over time. And I guess I'll start, Dr. DePlao. How consistent is that? 70% of clinicians not enjoying the direction that they're going with your experience?
I think it's accurate. I came out of the critical care environment where we already pre-COVID realized there was high burnout. It's a stressful environment. So nurses, practitioners, even before COVID, were experiencing burnout. And burnout comes with a huge cost. Number one is you have to hire back. So you're always having to train people over again. That comes with a cost. We also know that burnt out physicians, burnt out providers make mistakes, and that has a high burden. So we recognize burnout really early. That has nothing to do with EMR. Medicine is stressful. So once you recognize that, then I work in a health system that really values resiliency, right? And so we began to help our providers. Then EMR, yes, it's a tool. It's been demonized, and I would argue it's been demonized in a way. It's something that empowers me because it can give me a template. It allows me in some ways to practice. There are 10 or 15 things we do. If we make it an algorithm, we can get great patient outcomes. And we can do that efficiently. And then that leaves me time to help look into the patient's eyes. So yes, we spend time in front of that computer. There are other jobs we're doing I don't need to do. We do it for metrics, we do it for billing. I would love to remove that burden for sure, but I apply the 80-20 rule, which is 80% of the problems the patients have I can do with evidence-based guidelines. That allows me at that time to lift my head away from the computer, look into the soul of the patient for a second. Shakespeare says the eyes are the window of the soul, and then that 20% try to figure out what's your unique problem. I can take care of 80% of your problem with an algorithm, but then I have to get that uniqueness. So yes, I don't have an hour, 2 hours to spend with that patient, but if I use the EMR to empower me to do the work that I know will have good outcomes, I can now dig in and get a relationship. I don't do it in an hour and a half. I have to do it in 20 minutes. But I think we have a way to do it. To do that, you have to have an institution that allows you to help optimize your EMR, takes away the burdens. I'm not a secretary. I'm not a biller. Move that stuff away from me. So we need to re-examine our relationship with the electronic medical record. It's a tool. And my father was a carpenter, and my father said that a poor workman blames his tools. So we should really begin to, and again, I work in a health system, we were early in on this, to really try to optimize our electronic medical records. Having said that, many physicians have not built that relationship with them, and therefore they're unhappy. My message is, Viktor Frankl, who wrote about resiliency, said, you don't complain about something you can't change how you feel about that. So my argument is, let's change how you feel about the electronic medical record. That's the argument for resiliency.
So you also used an analogy yesterday about a fire truck.
Right. I have a 5-year-old grandchild. So you buy him a fire truck, and if he plays with it properly, we'll give him years and years of happiness, right? When the manufacturers made that fire truck, they made it with certain tolerances so it would last for a certain amount of time. And if my grandchild uses it properly, we'll give him a great deal of happiness. When he's throwing it against the wall, it breaks, and then he goes like this. And one argument could be go back to the factory maker and say, improve your tolerances. Make it so you can throw the fire truck against the wall. That's an expensive proposition. Maybe go back to my grandson and teach my grandson how to use the fire truck the right way, so you can enjoy years and years of enjoyment from that. I think the tension between administration and healthcare is, don't be surprised when you throw your providers against the wall and they break. As a provider, use me for what I'm able to do. I'm good at listening to people. I'm good at diagnosing. I'm not a very good biller, okay? I'm probably, don't do that very well. I'm not a very good typist, so maybe I need a scribe. So use them up as they were built, and we'll last longer. So that's my message to those doctors who are struggling. Work with your health system so that you can be used the way you were meant to be used.
So first of all, I love the analogy because the notion that we as a healthcare system or we as administrators in the healthcare system are actually using our providers the wrong way. First of all, the idea of using your providers is kind of perverse. Right. But the point here is I think right, which is we're failing them at some level as administrators, and I have to own part of that. We're not providing the right tools to them. And we shouldn't be surprised that they're retiring. We shouldn't be surprised that they're moving to part-time. We shouldn't be surprised that they don't enjoy their job. At some level, it is on, I think, both policymakers and administrators to start figuring out how to make the work environment work for our clinicians. And then I think that has a downstream impact on patients. And what I'd love to hear, Melanie, is, given how close your organization is day to day to patients with lots of longitudinal issues, is what we describe on the physician side, how does that impact patients at the end of the day?
I'm thinking about my puppy and how I can teach her to not destroy her toys instead of go to the toy maker to make them more durable. So I have many thoughts. I think the theme that I pick up from this is like this system is not set up to be successful for individuals, right? And particularly for complex individuals. We make it so hard. And then we say things like, oh, they're just not compliant. They don't do what we want them to do. We don't take the time to build trust, to build engagement, to give them a reason to feel like we're listening to them, and therefore make it successful, make it possible for them to be successful in this very complicated system that bifurcates every single part of their life, right? You have a medical need, you go here. You have a long-term care need, you go here. You have a behavioral health need, you go here. God forbid you need housing or food or transportation, or you're a victim of some sort of trauma or violence. And so what we're trying to do is kind of change that paradigm and be able to say to people, like, the number one thing, first of all, is build trust. And with trust comes engagement, and with engagement comes a way to just have a more meaningful and probably more positive experience with the healthcare system. And of course, I don't know that the system is set up for providers to be successful either, which is your point, that these two things then are really going head to head with each other. People always ask, well, so City Block got started in New York, and people said, well, how did you manage to hire providers? It wasn't hard for us to find providers because we came and said, we have a very different model. And this model talks about people are at the center, and this is how we're going to practice medicine. And so I think it was like being able to use providers the way I know we're not supposed to say used, the way they want to engage and the types of problems they want to do and the types of challenges they want to care for. And we're not great. I suppose I'll get in trouble for saying this, but we're not great at like EMRs, and we have really great workflows and really great care management systems that help us understand what's going on in our members' lives. But try to have us put that together with Epic, and that's not our strong suit, right? And so, but we purposefully kind of attack it that way. So the point being that I'd like us to like redefine how we expect providers and individuals to be able to be successful and to get pleasure from the healthcare system. And that happens at the policy level, but it also, it's driven by how we're paying for it, right? And what we expect of people. And so I know we're gonna get to that, so I won't jump the gun there quite yet.
We're definitely gonna get to that.
Yeah.
I've got one, so let me pivot the question a little bit. If you were to try to describe what you think your patients want out of their relationship with a clinician or with a health provider, what is that? How would you describe that?
They want somebody that's going to listen. So our co-founder and CEO, her name is Toyin. Toyin sees our members, and she has from the beginning. And she gives those members her personal cell phone. And we had this member who would just call, and Toyin would answer and she'd say, what's the matter? And the member said, nothing. I just want to know that if I call, you're going to pick up. And so I think it's as simple as that. It's just that nobody has ever picked up when somebody's called or somebody's texted. And so I don't think it's that complex. And it doesn't mean that they don't want you to be talking to them about what you're getting measured on for the star ratings. They want you to understand that something just happened to their grandson, or they don't understand the public charge rule, or they're worried about making their rent, And so but again, most providers are not equipped to be able to handle all of those things, particularly in how long is your average fee-for-service visit? 10 minutes?
For a follow-up would be 20, new patient 40.
Okay, well,
better in a lot of places.
I think that's what they want. I think they want people to listen and to be there when they want you to be there. And when they don't need or want you, they don't want you calling them and bugging them to come in for XYZ that checks a box, but actually doesn't help meet a need that they're having right then.
Yeah, and I think it is easy to assume that that's somehow unique to the patient population that City Block is serving. I don't think that's true, and I would even point to just the personal experience of the number of times a friend of mine has called up to say, hey, look, we're trying to navigate the healthcare system. We can't figure out where the hell to go. You at least know the system. Can you help me? Honestly, that probably happens 3-4 times a year for me among a set of relationships of pretty highly educated individuals who know the healthcare system on average better than many others. I'm still getting those calls. And that really, at the end of the day, is about finding the person who's going to listen and work with you. Is that?
So I agree with you. Number one, patients certainly want to be listened to, and the provider wants to be listened to, because at the end of the day, we're teachers. So I have my own personal experience where I called my provider because I wasn't sleeping well, and I said, I think it's the altitude sickness. And she texted me back and said, I think it's the altitude sickness. So I didn't feel heard. It was fascinating to me. I was mad. So I get it. So we want to be heard. That's the first thing. Work balance, that's the other side of resiliency, because at the same time, we want to be available to all patients. My patients have the 24-hour, but when you talk about burnout and resilience, when do you get the work balance? When do you get your me time? When do you get my time? So we have to have that balance. The beauty of a large health system is actually the weakness of a large health system.
Yep.
You have a large health system, you have access to many sources, you have deep pockets, but you can be monolithic. Our job is to have local, really different, regional climates, so that you can have, in your little part of the health system, you can have a system where you can listen, where you can have a system where you can resource it in a way that, you know what, let me do what I do best, which is I'm a good listener and I can look in your soul. I'm probably not the best teacher, so let me bring a nurse in to help teach. So we have moved to the point in my little microclimate, in my large health system, that I can surround my patient with a team. So they feel listened, and actually feeling listened by somebody who's better than I am. So they'd be taught by a nurse, they'd be getting their point of care service from somebody else, and I can do what I do well. And I'm satisfied because I know I'm getting heard. The patient feels satisfied because now they're being heard, and not only from one person, but from the whole system. So we should be building ecosystems within these large monoliths, which are health systems. We leverage the health system because they can pay for the EMR, they can help me optimize the EMR, they can get the billers to go get after the money. So, I think that's the way forward.
Yeah, I'll just add to that. I mean, that City Block is all about interdisciplinary teams. We don't put there's a lot that's done by what we call our community health partners. These are folks with lived experience from the communities where we're operating. And, that's not rocket science. It's not like we've figured out some magical thing, but it's another example of showing people respect, and giving them, I think, faith that somebody is listening and can understand. And so a lot of what I'm talking about is not addressed. It's not addressed by our providers or by our clinical providers. It's addressed by our social workers and our community health partners and our behavioral health specialists. And that's exactly how it should be. Our community health partners are spending a lot of time in housing court. That's a great thing for them to be doing. It would not be a great thing for you to be doing, right? And so figuring out how to get that balance, I think, is also really important. But it can be done. Like, these things we can shift those balances and put people sort of geared toward the best use of their expertise.
And so let me just ask, kind of a more provocative follow-up. If you push out 5 years and you say, hey, you've got social workers doing this, extenders doing that, et cetera, and you've got AI over here providing diagnosis and answers, and you've got a bunch of millennials who are saying, hey, I want to find my answer on the internet, or I want to be able to text with somebody to give me an answer. What is the role of physician? So we're saying that something isn't working, but if you push out 5 years, is there a role for the physician in 5 years, and what does that look like?
He's trying to get rid of you.
Oh, no. So, you heard that I was a specialist, and now I'm a primary care, and probably 5 years
You're gone.
No, I won't be gone. In fact, I'll be more important. If you read about AI, and there's a wonderful book written by two of our speakers who are going to be here later. AI is great. If you look at the chess masters originally, right, they couldn't beat the AI, but they beat the AI machines all the time. All of a sudden, the AI machines started beating chess masters all the time. Why? Because they would sacrifice their queen in the second move. No chess master would ever do that. They could not figure this out because AI just takes data and doesn't make a moral or an ethical judgment. So AI is going to give us a bunch of data, and if you're an athlete and you crush your leg, AI machine is going to say the best thing to do, most economic, the fastest way to recovery, amputate. But you go to the athlete, they're going, you can't amputate my leg. But the AI machine says, but listen, you'll be out of the hospital faster, you'll be out quicker, it's going to cost you less money. There's no morality applied. That's the role of the physician. The AI is going to give me good... The AI is going to give me good information, good data. But the physician, the providers, have to have the same relationship with the EMR and with the AI they have with the EMR. We've demonized it. It's not a demon, it's a tool. Use it. My dad told me, use people as you find them. Use the EMR as you find it, and use AI as you find it. It can give you good good conclusions. You may not understand it, because that's the other problem with AI. It comes in conclusions based on data, not on logic. And then you, as the human, look in that person's eye, say, what do you want? You're an athlete, you want to climb that mountain? It's my job to give you, if I have to amputate, or operate, do the least operation I can, get you the best prosthetic, and get you back on the mountain. That's my job. And that's going to be my role in 5 years.
Is that consistent with your experience?
Yes. Yeah, ours is, I mean, just the power of having eyes in the home, especially, and seeing kind of what the environment is and what's going on. And so AI can tell you that this person's insulin shouldn't have run out or has a plenty supply, but AI isn't telling you that there's no working refrigerator, right?
Yeah.
Or that there, any number of things like that. And so for us, and I think 5 years, it's going to be the same. It has to be a hybrid. There has to be touch plus tech. Tech without touch just is not going to do it, whether it's the population we're talking about or any of our folks.
But what I feel like I'm hearing you saying is that the physician's role is less about the diagnosis and more about how you translate that diagnosis to the individual needs of a individual human being, whether that's dealing with social determinants of health or whether that's an athlete dealing with their career or lifestyle needs. The pivot is translating diagnosis to something that's meaningful to a patient, whereas much of the role, I think, historically had been diagnosing. Is that a fair way to describe it?
It's going back to the way it used to be, because if you go back 100 years ago, we didn't have a lot to do. Right? We had no
real career people thought they were signing up for.
we had no surgeries, no all these advanced technologies. So we listened to the patient, and we maybe put some mushrooms. We heard about psychedelics yesterday. We made it up. So now we come all the way around again. We have a lot of data, which frankly we probably can't process. But what we can do now is really, go back in and help that patient because we listened to them. So we listened early on when we had nothing to do, and that was therapeutic. And now that we have a lot to do, we're still going to listen, but now we're going to take all this data. So I think, I view, I'm an optimist, I'm sorry, our role is going to expand because we're going back to our roots. We're going to listen to our patients and hopefully then help them as partners. We're not, the doctor has a story, we're paternalistic, that's gone.
Yep.
We partner with our patients to help them make the best decisions for themselves.
We see a lot of paternalism, I have to say. So I'm thrilled that it's gone at Sinai. I hope you can help. But we're constantly battling a belief about we're going to tell you what you should do and how you should do it and why you should do it. And so figuring out how we can get that right balance of listening and then being able to meet those needs. I don't think the paternalism is gone by any means.
Yeah.
I tell people I have my children and you're not one of them.
Yes. In the paternalism, at least part of that is a cultural bias that I think has been in medicine for a long time. Sure. And there's some real work that has to go into changing that cultural bias. What are the other things that are getting in the way of the clinician-patient relationship working the way you're trying to make it work at City Block, the way that you're describing it, and at times seeing it work at Mount Sinai? It's not consistently working that way. What gets in the way?
I have an answer.
Yeah, dive in.
3 letters: fee for service, FFS. At least in the environment that we're practicing in, we can't do what we do in a fee for service environment. We can't spend the time with folks. We can't wrap around their lives. We can't go to houses. We can't go to housing court. We can't do any of that in fee for service. And so we're really lucky when we find a partner who's got a non-fee-for-service construct, and we can partner with them, and we can have flexibility to get people's needs met in the most kind of respectful yet also cost-effective way. And so I'm not saying that that's the answer to all of our problems, but it would be a nice start if we could see continued movement and not just sort of window dressing value, but like true value and movement away from a structure that I don't think is driving toward any of the things we're talking about up here.
I agree with you, and I would just unpack it even further. We spend enough money on healthcare. We spend more money than most countries, and we don't get our value. So what is that? Fee for service. We spend money chasing dollars. That if we just gave us that money back, right? Just have to, I was in private practice for a while. I had 2 people doing nothing but than getting bills and getting collected. If you gave me that money back, maybe I could have more time. I wouldn't have to be. So that's the problem. I don't know how you get to that because that pays the rent. In our health system, we say, okay, that's the currency of the land. So we have to work for fee for service. But can we do better? Can we be efficient with what we have? The other impediment is we're not training necessarily our providers to do that. So part of our challenge is to identify struggling providers. And we have a very simple metric, patient satisfaction. We look at patient satisfaction, and if I have a struggling provider, I'm going to pair that person up because he's not happy. I'm going to guarantee you, the patient's not happy, that provider who gets a 2, he's not happy either, or she's not happy either. So then I identify them in my clinic, and I pair them up with a more seasoned person and say, you know what, learn to listen better. You weren't trained, not your fault. You weren't trained. You were in science, and you were in anatomy lab, and then you were in surgery. Let's train you better, become a better listener. And then, really trying to find the little value in fee-for-service we can to allow them to flourish. It's hard. It's a narrow margin, I agree. But it's not about more money. It's about just spending the money we have better.
And I think I heard you say yesterday that CityBlock is actually teaching effectively empathy skills. What does that mean? And why?
Well, I'm going to be a broken record here, just because it's all about trust and engagement. And so it's teaching people how to listen. It's teaching people how to not be judgmental and to not be paternalistic and do all of those things. And so you can train. I mean, we don't hire for of course we hire for technical skills, but we're looking for empathy because you can't train empathy in the same way. So you can we do train it, but we have to see it. And see that it's there, and it can sort of be cultivated more through what we put our folks through. But that's really, really important to us. And the type of experience, the way we want to show up for our members is all dependent on the ability of our care team to display empathy and respect and trust.
So let me pivot here for a second. So if you kind of walk through where we've been, we have a lot of unhappy people on both sides of the clinician-patient relationship. We have an important role that our clinicians need to play. It's a little bit different than it has been over the last 20 to 30 years, but in many ways, to your point, it's going back to where things were even prior to that. There's still an important role for technology. We can use it differently. We don't give our clinicians the right skill set. We're not training them and teaching them the right way. And so we actually have to augment that right now as health systems. And there are some cultural biases that we're trying to overcome, what you refer to as paternalism. Most of that we just talked about in the context of primary care. Is it really a primary care thing? Or do the same principles apply, albeit in slightly different ways, to the specialty community?
Well, that's a complex question, right? I think it applies to primary care because I was a specialist. And people look at me and say, you walked away from pulmonary to do primary care, what is wrong with you? And I said, what's wrong with me is I recognized the system was broken. The triangle was inverted, right? In New York City, everybody had a specialist. If you sneezed, you had a nose specialist. So that needed to be inverted. We needed a strong primary care platform and then allow the specialists to do what they do best. So I think it's mostly primary care, but a surgeon has to be empathetic. A surgeon has to listen, but it's a bundled piece of care, right? Most people, if you asked who your surgeon was 10 years ago, they'll forget who it was. But in that moment in time, that's the most intimate relationship that a person can have. A person's taking a knife and cutting into you. There's nothing more intimate than that. So for that period of time, all these principles apply. But then that person leaves their lives gratefully. You don't ever need to see that surgeon again, and then you forget them. But I would agree, I would suggest that for that moment of time, all these principles apply. So I think it does apply, even within the specialty models. I was a critical care doctor. If my patient was intubated on a respirator, there was not a lot of interaction going on at that time. So it's a different model.
Yeah.
But you better know their families I had a big relationship with. So even then, even if I wasn't relating with the patient, I was relating with their family members. Again, for a discrete period of time. Because when they moved out of the ICU, they were done with me. And I'm glad. They wanted to leave me in their rear mirrors. And that's what we want. So I think it applies in both primary care and in specialties.
Yeah, and we are much more oriented to specialty care. My background prior to this has been primary care. I agree with you that it's very easy to explain why these principles are so important within the primary care setting. But we're wrestling with all these same issues right now in the specialty space that we operate in. When we do team-based medicine, it is better than when it is individual. When we are creating the environment where we have real one-on-one interactions with patients and we're doing the listening, whether it's on the front end of the surgery or whether it's at the discharge moment from an inpatient experience, those are in many ways the most important part of the interactions. And I think even if you stare at something in some ways, it's almost difficult to fathom, but if you look at even malpractice cases that occur in the specialty space, they're much more correlated with, did the clinician establish a relationship and trust with the patient than it is on the clinical outcome. You can have a good clinical outcome and no trust and end up getting sued. You can have a less than ideal clinical outcome but have the trust of the patient that you're going to get it corrected and you're not going to get sued. So it is, in many ways, again, you have to apply the principles a little bit differently, but the principles are still there. And I would suggest that the same way that we need to see these things evolve over the next 4, 5, 6 years in the primary care space, we also need to see them evolve in the specialty space.
And that trust has to be bidirectional, because you don't want the provider looking at the patient and wondering, are you going to sue me? Because that's not a good platform to start a conversation. How do you get around that? Number one, my job is to make you trust me, but also, as an institution, have a culture of safety.
Yep.
Because if you have a culture of safety, then you know these mistakes won't happen to begin with. So part of the way I can feel trustful when I sit down in front of my patient that something that I can't control is going to happen, because I know I have a safety cushion behind me. I have a culture of safety behind me where that my EMR is not going to make a drug medication error. Okay, my processes are not going to make me forget to do something that's going to have value added. So I can approach that table and not be looking at my patient and saying, are you going to sue me? And then my job is to say, you're not going to sue me because you like me. So it's a little bit of both.
Yeah, I would just add, and again, this may not be representative for everyone, but our members, they're not looking to make sure that the system has a tight policy on safety. They're looking to see, do you have a policy on racism and bias and those types of things? And so I think the bidirectionalism, there has to also be kind of putting something behind what we all say we're trying to root out of the healthcare system, and that I think is really important at the specialty and institutional levels as well. And those things matter to real people.
And fundamentally, I guess, again, there's an important role for the clinician. That role more and more and more is about how do you understand the patient's individual needs outside of the clinical need. It's all the things that impact the clinical need. And how do you translate the clinical needs or expectations or requirements to meet where that patient is at? Requires more time, requires more trust. And that's where we have to get back to. And it actually leads to a lower cost system at the end of the day with better outcomes. But I think we as a nation, as a healthcare system, actually have to start putting our clinicians back in the middle of healthcare. Because at some level, what years of fee-for-service and what years of EMR rollouts has done is it has marginalized that role, not intentionally. It's not like anybody said, hey, we're going to go marginalize the role of the clinicians, but it has been a secondary impact. And that's the fundamental thing that I think needs to flip as we continue to try to push the healthcare system forward. Anything else that either of you would like to say before we kind of open it up for a few minutes to questions?
I absolutely agree with you, but it can be done on a grassroots level in terms of, I work in an environment where I'm allowed to put the clinician back into the middle, and as long as I don't lose money, I'll be okay. And so we get to really work and figure out, how I can put the clinician as part of the conversation, but not in the center.
Yep.
Okay, the patient sits in the center, but as a clinical director, I am allowed to, work with my people, work with the amount of budget we have to make it happen. And I think it can be done if the health systems support that. It's going to be different in primary care, in that specialty. Each ecosystem is going to require a different approach.
Yep.
And so it almost can't come from the top down. It has to come from the bottom up.
I would just add one thing. It's not always, sometimes it's going to cost money in the beginning. And as we're making this transition and the things we're talking about are investments that are going to pay off. And so I think that having the luxury of having sort of understanding that there's an investment horizon in order to do some of these things. If we go in believing that all of these things have to be budget neutral or budget saving, particularly in the first year, we're never going to make any of these changes. And so at least in the worlds I run in,
and that's my plug for philanthropy.
So let me open it up. Yeah.
Hey there, thank you. I wanted to maybe just challenge a little bit the notion that trust is what it's all about, or that the relationship is what it's all about, because I teach doctors at the school of public health, and I always ask them, like, how many of you know your patients? And there's usually one person who's like, I know all my patients. Everybody else is like, not a one, because they have 2,000 of them. There's no way they can keep up, right? And my view is the patients experience a healthcare system that's really unreliable. So you try to make an appointment, you can't get it done. You can only call, when you're supposed to be working, right? Or you show up at the appointment, but the doctor's not ready to meet with you because they're late. Or they say, go do this, but then when you go to the lab, they're like, we didn't get the requisition. Or then you get 5 bills for the same appointment, right? So I think people experience the healthcare system as like incredibly unreliable when it comes to just executing tasks compared to, say, Amazon or someone who's like really good at execution. So I guess what I'm asking is, do people really want trust, or do they just want things to work the way they're supposed to work, conveniently?
I think they want both. I mean, I would agree with you. Every provider is someone's patient. So I've been a patient as well, and you're right, it is opaque, and you struggle with it. And I gave you my example of getting mad at my own primary care provider, who's very good. So yes, we have to figure that out, and we are not Amazon. But I will tell you, my patients trust me. I let them know my life. I try to know their life. So if you asked my patients, I think they would tell you they trust me. I hate the fact that the lab doesn't answer the phone. I hate the fact that it takes me 5 phone calls necessarily to get through to you. But I'll listen to that and say, maybe I can do a better job. They want both, right? They want it to work, but if I go back at you and say, take a choice. You can have Amazon, or you can have somebody who's a trusted provider, and see what their answer is. I think they would want that trusted provider.
I also think the two things are somewhat interrelated. When you are failing at basic tasks, or the team around you is failing to meet basic tasks, you've destroyed trust before you've started. And if you don't have a prior trusting relationship, you have less tolerance. I mean, we all know this, right? Like with whoever we're dealing with, if we have built a track record, we can live with an error. When we don't have a track record, that error becomes, often the end of a relationship before it's ever begun. So I do think that these things end up being more interrelated than not. But I also think panels of 2,000, and again, it depends a little bit. If it's 2,000 healthy millennials, it's one thing, right? If it's 2,000 of the rest of America, then it's too many. And so that is part of the we don't have enough primary care. When we have primary care that's focused on seniors and those panels go down to 700, they actually are building relationships. They are working through issues, and there are many examples of that. So I think the two things are interrelated at the end of the day. Oh, whoa.
Thanks so much. My name's Andy Foley. I'm a family physician. I appreciate your presentation. My question was about, actually sort of goes off of this, of how we can pay for the things that we are now realizing how much they are valued. And I think this question of do you pay for trust, do you pay for things to just work? I think the pandemic showed us that the vaccine was available at CVS 10 minutes away, but having that relationship with somebody that you could talk to about why it was important to get it and all of those things, realize the importance of having that relationship and having that trust, especially if you're somebody who has lots of reasons to distrust the health system. So my question as a family physician, one thing that's always challenging is who's at the table for hospital administration, and understandably the specialists and the folks who are bringing in the revenue often get that voice at the table. And how do we, if you have any comments on sort of, how do we change that a little bit to say, yeah, we're actually going to be paying for these conversations that we realize are so important, that don't take the technical skill that might be reimbursed by the RVU system, but that we're realizing are just as important or just as complex, or take that same level of training and cerebralness that we apply to much of specialty care, much of surgical care, that right now is really fueling the payment system, and for big hospital systems especially, but all the way down to our community health systems. Thanks.
Well, certainly risk contracts begin to drive that conversation, correct? Because if you as a health system, we're in Harlem, geography is everything, so we live on the richest side of the city, and we live on the poor side of the city. And we take care of both populations. If we start taking contracts at risk, now we're responsible. All of a sudden, everything you just discussed becomes very important. They better get vaccinated. If they don't get vaccinated, they're going to get COVID, and they're going to wind up in the ICU, and they're going to spend a month, and I've just lost money on that patient. So all of a sudden, primary care becomes very important. And our administration is paying attention because we can't lose money. So that's how that's how the family doctor, the primary care doctor, gets a seat at the table, because with these contracted at-risk populations, just as you're doing, we're on the hook. Right? We'll get a nice bit of money. If we do a good job, if we're preventative, we'll hope break even, or maybe even make some money so we can do more. We can do more. If we do it badly, we're going to lose money very quickly. We're going to lose our shirts. So that's how we get the foot at the table, at least in my health system. We take on risk contracts. We have to balance that, obviously, because we are at risk, so we service our other populations. So then you heard the other side of the tracks, that's 98th Street. So we're on the other side of the tracks, we have insurers so that we can balance and have a good patient mix. So our leadership is listening to both, I think. I'm pretty confident that we're listening to both.
We haven't had that kind of luck with the systems as much. So we started out thinking like it made natural sense for City Block to partner with systems because the relationship is at the provider system level. And if we're successful, we're keeping people out of more profitable hospital beds, right? And so it does become a challenge. The managed care plans have been easier to, I think, provide to front load incentives on the primary care side because they're seeing that value. In the I don't know which populations you serve. In the Medicaid, some of the state Medicaid policies that are requiring value-based arrangements, and some of them define them more rigidly in a good way than others, are actually wanting to see demonstration of extra dollars going into the primary care system, like specifically for the primary care system. So I think policy changes, which may feel distant and may feel slow, I do think that's an important thing to make sure that if Medicare and Medicaid, the two biggest payers, are starting to speak with their pocketbook and starting to force payers or systems or hospitals, whoever it is, to demonstrate increased investment on the primary care side, like they're doing with some of the Medicare initiatives. I think that helps move the system.
Hey, I want to thank everybody for their questions, and I'm being told that you will miss your next meeting presentation if we continue with Q&A. So thank you all. We're happy to take questions afterwards if you'd like. And